to record. Okay. So today's lecture is going to be all about both testing and understanding kind of the hows and whys behind something called cardiorespiratory fitness, or CRF. Okay. So this is a separate type of fitness from muscular fitness. So if you remember way back, what seems like to me forever ago on the first couple of days of class, we talked about, that fitness is your ability to do something. Like, are you fit enough to do X, Y, or Z, to run a mile, walk a mile, do 10 push-ups? So in your first lab, kind of what you guys just turned in, the goal would be to assess muscular fitness. So what is your maximal strength? What is your local muscular endurance, as judged by how many push-ups can you do? How many sit-ups can you do? So that tells us something about the function in the neuromuscular system. So this type of fitness is somewhat more integrative of multiple systems. So there's going to be a component of kind of muscular function involved in cardiorespiratory fitness, but what it really gets at is endurance capacity as determined by your cardiovascular and pulmonary or respiratory systems. Okay. So the reason that we need to spend some time talking about this is, if you remember, I showed you guys some data in the muscular fitness assessment lecture that we could predict how long you were going to live based upon how strong your legs were. And I believe that I told you, even though I didn't show you the data, that we could also predict mortality rates or predict how long you're going to live by measuring grip strength. Okay. So if we accurately assess your cardiorespiratory fitness, then we can, even more strongly than we can with strength, we can predict your risk of mortality. Okay. So because cardiovascular disease is one of the leading causes of death, and cardiovascular disease of all types is going to have very, very, very negative effects on your cardiorespiratory fitness, then people that have higher cardiorespiratory fitness are going to have a lower chance of cardiovascular disease, and therefore they're likely to live longer. So this is, of all of the measures that we're going to go over throughout class, okay, of all of the things, this is, if we can make a good estimate of it, this is the variable that is going to be most strongly predictive of mortality rates. Okay. So of all of the things that we're going to see in class, of all of the things that you can train to try to modify to make yourself at less of a risk of dying from anything, this is the one thing. Okay. This is the one thing. All right. So in conjunction with that, and we've mentioned this already, what we see is that high levels of cardiorespiratory fitness can help to offset much of the mortality risk that is associated with being overweight or obese. Okay, so the terminology has fallen out of favor to some extent, but when I was a graduate student in the early 2000s, as these data were beginning to emerge, there was this concept of being what they would call fat but fit. And what they really mean is you are obese, but you're very active, and therefore you're very fit. And those people had mortality rates that looked a lot like regular weight, but sedentary, or in some ways even regular weight, but also fit individuals. And so the thought is that if you can train in a way to improve cardiorespiratory fitness, so that you can train your cardiovascular system, you don't really train your pulmonary system very much, but you can prevent some diseases from occurring there. So if you can train cardiovascular health, then that will offset any of the negative effects that may come along due to obesity. Okay, so this is a really, 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 really important variable and a really important concept for understanding this idea of the relationships between fitness and health, which is in some ways the point of this entire class. Okay, so what I want to show you guys here, these are data that I've already shown, okay? But I'm going to bring them back up again to try to drive home this idea that if we can assess cardiorespiratory fitness, it will give us an even better picture of mortality rates. So these are some data that are assessing your relative risk of dying from anything, relative risk of premature death from anything. On the x-axis, it is where you fall in a percentile rank based upon either how active you are or how fit you are, okay? And so last week we talked about this physical activity portion, that when you are more active, being active is going to be some ways protective from cardiovascular disease and diabetes and excess mortality rates, okay? Being active is good, but being active in such a way that it is going to lead to improvements and elevations in cardiorespiratory fitness, which is what they're showing in the bottom line here. What they're calling this physical fitness, what this really is cardiorespiratory fitness, okay? Fitness has an even more powerful sort of positive effect on risk of mortality than just simply being physically active. And so the take home to me from this is that activity is good. Walking around is better than not walking around, okay? But as you guys will see as the lecture progresses today, that in order to improve cardiorespiratory fitness, especially for folks that are y'all's age, simply walking is probably not going to be intense enough to provide an overload on the cardiorespiratory system to lead to kind of marked increases in cardiorespiratory fitness, okay? You guys, and a lot of people that are even my age, you guys need to jog or run, or you need to ride the bike at a relatively higher intensity, or if you're going to walk, you need to walk fast and you need to walk up a hill or something, okay? So activity good, more kind of intense activity that will drive changes in the cardiorespiratory system, even better, okay? So that's kind of where we are. All right, anybody have questions about that so far? Hopefully I have somewhat convinced you of the importance of all of this, okay? Of the importance of all of this. Okay, so I've made this list, and this list is going to look a whole lot like the similar list about why were we testing muscular fitness, okay? But why do we want to test this? Why do we need to know what your cardiorespiratory fitness is? Well, it helps us identify where you are right now, okay? During the test, we can, if done in a controlled manner in a laboratory setting where we can make accurate measures, it can help us get some insight into whether or not you are experiencing kind of correct physiological responses. If you're having an abnormal physiological response to increases in activity, which is how we test this, then that will tell us there may be some underlying pathology. One of the things that happens if you have a heart attack, or they suspect you of having a heart attack, when you get to the hospital, as soon as you are stable, as soon as they think your life is no longer in danger from what's going on, they throw your ass on the treadmill and they start having you walk faster and faster and up a steeper and steeper incline with an EKG on, to in essence see if they can make you have another heart attack, and they can identify some sort of abnormality on your EKG and use that to try to diagnose kind of the hows and the whys of your cardiovascular problem, okay? So people that are immediately post a heart attack are going to have their cardiorespiratory fitness assessed, okay? So it's called a stress test, and that's really, really important and helpful diagnostically. So knowing what your cardiorespiratory fitness levels are can provide a basis for exercise programming, right? If we know that you are fit enough that walking is not going to be sufficient to help make you more fit, then we need to know that, and then we can use that to prescribe jogging or running or cycling or ellipticaling or whatever it might be, okay? As I said, it can help us screen for coronary heart disease, either after a heart attack, or like my dad goes every couple of years and he's never had any heart problems, but every couple of years he gets a stress test done just because of his age, and it is helpful for screening for coronary heart disease. Um, so you need a certain level of cardiorespiratory fitness to be able to perform certain work tasks. Not at OU, but when I was at Ole Miss, and when I was at my first job at Georgia College, we would run tests on university employees. Oftentimes, it was the men that worked in the physical plant, the guys that had to lift a bunch of things as part of their job and had to do some pretty high exertion things. And if they would have a heart attack or they would have something going on, HR would have them come to us, we would test them, and then they would take that to their physician and they would get signed off that they had a sufficient capacity, they had a sufficient level of cardiorespiratory fitness to be able to perform the work that was required of their job. So before they could go back, they had to have some of that stuff done. So we can use these kind of tests for that as well. And then it lets us know if our training programs, like if you've been training and we have a pre-value, we can test you afterwards and see, are you making progress or not? Or have you been being like me and you're being a slack ass with your training, and so you're probably not getting any more fit right now. Okay. So of all the things we talk about today, this is probably going to be the most kind of conceptually difficult, is trying to define the things that go into determining cardiorespiratory fitness. Okay. So up until now, we've been calling this cardiorespiratory fitness. The variable that we measure in the lab, okay, that is cardiorespiratory fitness is something called VO2 max, okay, VO2 max. The V stands for volume, the O stands for oxygen, okay, and the max is going to denote that it's the highest amount or the highest rate of this, okay. VO2 max is, at its most basic, it is a metabolic rate, okay. It is a rate at which your muscle cells are able to take oxygen out of the blood, take it into their mitochondria, turn it into ATP, so that that ATP can be used in the cross bridge cycle to help us repeatedly generate force production. Okay? So the higher your VO2 max, the more oxygen that you can take into those muscles, the more oxygen you can use to make ATP. Therefore, the more ATP you're able to make. And so that allows us to generate higher rates of force for longer periods of time without getting fatigued. Okay? So VO2 max is what we call an integrative measure. If you have to be able to bring the oxygen in from this outside air, bring oxygen in into your lungs, diffuse it from at the alveoli from the lungs into the blood, bind it onto the hemoglobin, get it back to the heart, have the left ventricle then send that blood out into systemic circulation. We have to be able to dilate our arterioles to send the oxygenated blood to the working muscles. Then we have to be able to diffuse the oxygen out of the capillaries into muscles and use it in the mitochondria. So this is a more integrative. There's more systems, more tissues that need to be involved in determining VO2 max than, say, simply determining your 1 rep max strength. That's kind of a nervous system and a muscle kind of size and recruitment issue. This is many more systems. And so what that should hopefully let you guys understand is that there's a lot of places where things can go wrong that can adversely affect your VO2 max. Okay. I can make your VO2 max go down by taking you to altitude where there's less oxygen in the air. So there's less O2 to bring in. I can make your VO2 go down by giving you some sort of pulmonary disorder. If I give you emphysema, so you cannot bring in the air and you can't diffuse the oxygen into the blood as well, that makes your VO2 max go down. If you have a cardiovascular impairment whereby your left ventricle shrinks or your blood pressure is elevated, so your stroke volume falls, that's going to mean your cardiac output isn't going to be as big. So you can't circulate as much blood. If you have a problem in your capillaries, okay, or you have problems of not having enough mitochondria in your muscles, these can all affect this, okay? So that's what VO2 max is. So every time I refer to VO2 max, I mean cardiorespiratory fitness. And when I say cardiorespiratory fitness, I mean VO2 max, okay? In a very, very, very general sense, the higher your VO2 max, the better of an endurance athlete you're going to be, okay? So the higher your VO2 max, it's more likely you can run a mile or a 5K or a 10K or a marathon faster than somebody with a lower VO2 max. In my graduate advanced exercise physiology class, we get into some of the details of that because it's not always, there are some exceptions to that. But in a very general sense, if we were to measure VO2 max in all of you guys in class, and we were then going to have everybody run a race for who could run 2 miles or 5K the fastest, the highest VO2 max, as long as they were trying as hard as they could, would probably win that race. Okay? Okay. So there are two physiological components that are going to help determine what VO2 max is. And I've mentioned all of those in kind of the previous kind of explanation of what it is, but I want to give you these because we talked about them the last couple of days in the cardiovascular lecture, okay? At your maximal rate of sort of metabolism, you will max out cardiac output. So cardiac output is, weirdly enough, abbreviated Q, okay? We can thank the Greeks or the Romans or whatever for all of this, but so Q stands for cardiac output. So when you max out cardiac output, we are saying that you're maxing out the body's ability to deliver oxygen via the blood to our working muscles. Okay. I also mentioned to you guys, I believe it was yesterday, there is a variable called AVO2 difference, or arterial venous O2 difference. And this is our way of trying to estimate how much oxygen the muscles are taking out of the blood in the capillaries, okay? And we make a somewhat misguided assumption, but it's mostly true, that all of the oxygen that gets extracted out of capillary blood into a muscle is going to make it to the mitochondria, and it's all going to be used to make ATP, okay? So the physiological components are delivery of oxygen by the cardiorespiratory system, and then utilization of that oxygen by the mitochondria in the muscles. So together, these two things are going to determine. So if I can do something to make one or both of these go up, my VO2 max increases, or if something happens to one of those where it falls, then my VO2 max is going to go down. Okay? We express this via something called the Fick equation. Okay, the Fick equation. I guess maybe if you've made it as a scientist, they name an equation or something after you. But the Fick equation tells us that oxygen consumption, or VO2, is equal to heart rate multiplied by stroke volume, so cardiac output, how much blood is getting to a tissue, multiplied by our AVO2 difference, or the amount of the oxygen that is getting there that is being taken out of the capillary blood and utilized inside the muscle. Okay? So we've been talking about cardiorespiratory fitness. We've been talking about maximal amounts of oxygen consumption. If you note and you look at the Fick equation, it just says VO2. Okay, it doesn't say max. We can put max on there. VO2 max is maximal heart rate multiplied by maximal stroke volume multiplied by maximal AVO2 difference, or maximal extraction and utilization. Okay. However, all of you right now, as we sit here, right, you have a metabolic rate. You are using some energy. So we can measure your oxygen consumption at what we would call rest right now. We can measure it in all of you. And what it is right now is determined by what your heart rate is, what your stroke volume is, and what your AVO2 difference is going to be. Okay? So you can imagine then, under a scenario where if I ask, say, Whitney to stand up and start doing some jumping jacks for us, her heart rate would go up. If her heart rate goes up, then her cardiac output goes up. If her cardiac output is going up, we can make the assumption that her energy expenditure or her metabolic rate is also going up. These things change in concert with each other. Okay? She does jumping jacks, it goes up a little bit. We have her do some like running in place, it goes up even more. Heart rate goes up more, stroke volume goes up more, utilization goes up more. So all of you have, at any period of time while you're alive, you have a certain oxygen consumption at that moment. And if we ask you to do some kind of exercise related task, okay, and we make the demands of that more and more intense, then your oxygen consumption is going to gradually increase. Okay, that is denoted here in our graph. What you can see is a measure of oxygen uptake, or a measure of oxygen. We call it consumption or uptake. It's the same. This is VO2, and then this was performed on an exercise bike. Okay, so the person has gone to spin class, let's just say, and you start off sitting on the bike here, and then you crank up the resistance on the bike every 30 seconds or every minute, and we measure the corresponding change in energy expenditure, the corresponding change in oxygen utilization. And so what you guys can see is that as the work rate, as the resistance on the bike increases, there's this very linear increase in VO2. At some point out here, okay, I increase the resistance, but my VO2 doesn't go up anymore. That tells us that we have reached the maximal ability of the cardiorespiratory system to deliver oxygen and to utilize it in the mitochondria in our muscles. Yet you will note that we maxed this out, but the person in this instance was able to do a little bit higher work rates. Okay. All VO2 max tells us is the amount of energy that we can derive from aerobic metabolic pathways, purely from the mitochondria. Okay. We don't talk about it in this class. I'm sure you talked about it in human phys. You probably talk about it in personal training. I know you're going to talk about it in exercise physiology, but there are several anaerobic energy pathways. Okay. There's the utilization of creatine phosphate that's stored in your muscles. There is glycolysis, where you take glucose and you make lactic acid that's going to get you some energy as well. So even when you max out aerobic pathways, for a short period of time, you have additional energy that can be provided anaerobically that will allow you to work at a slightly higher rate. Okay, so that would be how we would normally determine VO2 max in the lab. Okay, we would put me on this treadmill that is sitting out here next to me, start me off at a walk on level ground, and you would just increase the grade on the treadmill every minute or two, and I would just walk until I could not go anymore. Okay, or the easier way for people that are reasonably fit is you just have them jog, and then you increase the grade every couple of minutes, and they just run until they cannot go anymore. Okay. All right. I feel like I've thrown a lot at you guys about all of this. This is one of the more, because it's so integrated, one of the more difficult conceptual things that we cover in all of class. So I want to take a minute and give you guys a chance to ask any questions about that you may have right now. Anybody have any questions? Or have I confused you all so much that you don't even know what it is that you don't know yet, and you can't ask a proper question? Anybody? Okay. Seeing that there are no questions and no objections, then we will move forward. Okay. So when we normally do our lab in relation to this, we have you guys ride a bike, and we do an estimation protocol on all of this. We're not going to be able to do that this time. That's why we're going to have you guys try to do a walking test where we can give you a certain amount of distance or a certain amount of time and figure out what you can do, and then we can find something that may actually correlate with your VO2max. All right. These numbers and their units are going to probably be meaningless to you, but I do want you to be aware of them, okay? Because when you derive a value from lab, you're going to compare yourself to some normative values based upon age and sex, and I want you to kind of be able to have some context for how fit you are. So we measure the units of measure of VO2 max are going to be milliliters of oxygen per kilogram of body weight per minute. Okay, mLs per kg per minute is how we very often refer to this. Okay, so this is trying to get at, based upon your body size. So your weight is going to have a way for us to account for how much muscle you have. The more muscle you have in your body, the higher your VO2 max can potentially be, because the muscle is where the mitochondria that are going to use this are going to be. Okay, so typical values in kind of normal college-aged women, healthy college-aged women that are not particularly fit, their VO2 max is going to be somewhere between 30 to 40 milliliters per kilogram per minute. Okay, men, college-age men, are going to tend to be somewhere between about 35 and 45 mLs per kg per minute, right? So this is going to give the appearance that the typical average college-aged male, independent of how active or trained they are, is a little bit more fit from a cardiorespiratory standpoint than women, okay? This is somewhat true, but somewhat not, and it's kind of it's a consequence of something that makes men and women a little bit different. Does anybody want to guess at what that is? Who weighs more, men or women, typically?
Men do.
I'm sorry?
Men.
Men typically weigh more.
Men typically weigh more. Very good. So if you've got a value and you're dividing it by weight, if men tend to weigh more, wouldn't you expect men to have a lower value? If your denominator in your equation is bigger, wouldn't you expect them to have a lower value? And yet, in general, they don't. Okay? So men do tend to weigh more, but what do they also tend to have more of and less of in general than women, as it might relate to that weight?
They tend to have less fat.
That's right, Corey. Men tend to have a lower percent body fat and a relatively higher percentage of their weight that is going to come from muscle. Okay, so women tend to have a little bit more fat and a little bit less muscle. The wonders of childbirth, ladies. We're going to do body composition and some obesity stuff starting tomorrow, so we'll talk a lot more about all of that. But that's what's going on. And so if we need muscle, because muscle's where the mitochondria that are going to help us use this oxygen are going to be, the fact that men tend to have more muscle is going to tend to make their values a little bit higher. Okay, so in general, ladies, y'all are penalized because of a higher percent body fat. Okay. If we can match men and women on body size and body composition, so you have men and women that are basically the same height, the same weight, and have the same relative percentages of fat and muscle in their body, then their VO2 max values, there tends to be no sex difference between men or women. Okay, a lot of it is driven by the increase in muscle in men and the increase in fat in women. Okay, so I saw something in chat. Yes, Kylie had put body fat. You're absolutely right. Okay, so in women that are elite distance runners, okay, elite, think Olympic level, like professional marathon runner, professional elite distance running types of athletes, or other populations that tend to have really, really high VO2 maxes, rowers. If you guys know anyone that's on our rowing team, when I first got here, we had a girl that was a master's student in our department that was on the rowing team, and her VO2 max was 72 mLs per kg per minute. So elite female distance athletes tend to be somewhere between maybe 60 and 75 mLs per kg per minute. Okay, I believe the highest ever recorded in a woman is 77 mLs per kg per minute. Okay. So you can think that an elite distance athlete who is a woman is going to be close to, her VO2 is going to be close to double what kind of a normal sedentary college age person is going to be. Okay. In men, again, because even at the elite level, women are still going to tend to have a little bit more body fat and a little bit less muscle than men. In men, they're going to be somewhere between typically 75 and 85 mLs per kg per minute. Okay, I believe the highest recorded in men was in a guy that was a cross-country skier, and it was 97 or 98 mLs per kg per minute. Okay, it's just giant value. Okay. Conversely, on the bottom, I have typical VO2 max values for a couple of pathologies. Okay, so people that have just had a heart attack, so you're a myocardial infarction patient, they're going to tend to have values that are maybe in the high teens to the low 20s. So their values are about half what a typical average college age woman is going to be, and a little less than half than a typical kind of sedentary college age male is going to be. If I told you guys that to walk upstairs, it's going to take maybe, I don't know, depending upon how many stairs you're going to cover, it's going to take 20 mLs per kg per minute of metabolic rate to be able to walk upstairs, then you can see why in people that are post-heart attack, that's very, very near their maximal value. So it's hard for them to do anything that requires more energy expenditure, more force production than like walking upstairs. Okay. People that are pulmonary patients, if you have chronic obstructive pulmonary disease, if you have pretty severe emphysema, then you're going to be even further reduced in your VO2 max. So pulmonary patients may be in the mid to low teens in their things. Okay, you guys go out and walk right now. Just go walk around the block, and some of you, depending upon how fit you are, depending upon how much you weigh, most of us are going to be somewhere in the mid to low teens in our metabolic rates, our VO2 values, just during kind of normal walking. That doesn't cause us to breathe heavy, doesn't feel difficult to us at all. And so then you can imagine why the pulmonary patients have a hard time doing anything. Okay. So our myocardial infarction patients have impairments in the cardiovascular system, so they cannot deliver. Their cardiac output has fallen so much that they can't deliver the oxygen to their muscles to be able for the muscles. They may have mitochondria in their muscles and an ability to generate force and use the oxygen, but they can't get it there. In our pulmonary patients, their cardiovascular system may be fine, their muscles may be fine, but they cannot diffuse the oxygen from the air across the alveoli and get it into the blood to be able to circulate it. Okay, so each of these are going to kind of create these unique challenges, and I just want you all to be somewhat aware of VO2 determines what kind of activities you can do without feeling like it's very effortful, without getting out of breath. And if somebody has a hard time doing that, then there must be an impairment or a pathology in one of the systems that's determining your VO2. Okay? Everybody with me so far? Kinda, sorta, maybe. Gonna get some thumbs up or some nods of heads or like something. Okay. Lindsay and Whitney are with me at least, so I got 2 of y'all. So if anybody has questions, and you got to ask Lindsay and Whitney, and maybe Corey if they've got all of this. Okay. So those are some typical values. All right.
I have a question.
Of course.
Just for that.
Fire away,
So
please.
when they test for VO2 max, do they just have them go just dead on, fully exert themselves like a max sprint until they can't go anymore? Is that how that's done?
So that's a great question, Preston. So generally, we don't start off that way during the test, but you end the test doing all of that. So methodologically, the way that we measure this in the lab is we hook you up to this crazy, and I should have put a picture in here, but we hook you up to this crazy contraption, and it runs these tubes in, and you put you breathe into this mouthpiece, or you breathe into this mask, okay? And the mask is open on one side so you can bring regular room air in, but then when you breathe out, we collect all of the air that you're exhaling, okay? And we run that through some gas analyzers. And if we know the concentration of oxygen and CO2 in the air you're breathing in, and we can measure the concentration of oxygen and CO2 in the air that you're breathing out, what typically happens is O2 in the air that's being breathed out is lower, CO2 is much higher. We can do some back calculations then on how much oxygen we think you're using in your muscles. But to do that, we need to get multiple breaths, and we need kind of about a 30-second window of time at a given work rate to be able to get a good average measure of what's happening. Because it's the way the measurements work is if you just capture one big deep breath, that's not going to give us enough data. It can skew things. So we need you to be at a work rate for typically 30 seconds to a minute to get a good sound reading. So because of that, we often will start people at very kind of moderate levels of exertion. Like if you were to come to my lab and we were to test this, I would tell you to get on the treadmill and pick a speed that you could jog at for half an hour, basically. It's not going to be that difficult for you, okay? And we start you off on the treadmill with it being flat, and then we would go for 2 minutes with it flat. We'd collect all your gases. We'd figure out what your VO2 was for that. Then we would start to increase the incline on the treadmill, or we could leave it flat, but we could go half a mile an hour faster or something, right? And we do that for a couple of minutes, and then we measure your VO2 during that. And we slowly increase these things so that we can keep you at a particular work rate long enough to get a good stable measurement. Now, what happens at the end is that the treadmill is either going fast enough or the grade is such that at the end, you are going all out. It's all you've got, but you're really giving all you've got for, a minute or 90 seconds or something like that. And that's how we know that we're kind of maxing everything out. Then we want to get really, really crazy. You do that, and then we let you rest for a half an hour, and then we put you back on the treadmill or back on the bike at a faster pace and a higher incline than what you finished at. And we try to make sure that when we start you there, when you're less tired from doing things, that your VO2 doesn't go up any higher. That's called a validation protocol. So So at the end, we're going to get the VO2 max measurement during what's going to feel like all out. But to get you there, we have to kind of gradually ramp you up to that. If that's kind of a long-winded way of answering your question. I hope I did that okay. All right. So, very good. All right. Other questions? Okay. So, other considerations. What that are going to influence your VO2 max. So if we were to make a measure in all of you, I've already talked about that men tend to have higher VO2 max values than women. Young people tend to have higher VO2 max values than older people, all things being considered. Part of that is because you guys have a higher max heart rate, and so therefore you're going to have a higher maximal cardiac output. The other issues is that as we age, our cardiovascular system and our pulmonary systems and our muscles, those are going to be more sedentary. We tend to be less well trained, and there can be some pathologies that are going to be there. There's a very, very large genetic component, maybe anywhere from a quarter to almost half of the things that influence VO2 max are attributed to genetics. So if you have parents that naturally had high endurance capacity, okay, that they were good at that, then you're going to have a much better chance of having a higher VO2 max. Even if you've never trained, you've never done anything else, some people just have naturally very high VO2 maxes. Okay. The type of test that we do plays a little bit of an influence. So I could take Maddie and we could have Maddie do a VO2 max test, and we could put her on a treadmill and have her run, and that would give us one value. Running is the best, most accurate way to get us these things because running uses the most muscle mass. Okay, running, you use your legs, you're swinging your arms. When you run, okay, you're using more muscle mass and you're maxing out kind of your cardiac output and things the most. We have Maddie get on a bike then the next day and do the exact same test, but do it on an exercise bike, a spin bike or something. And her values are probably going to be maybe 5 to 10% lower on the bike than they are versus running. If we had to do something that's very common in physical therapy and occupational therapy, where you just do an arm crank cycle, you just ride with your arms, then your values are going to be anywhere to maybe a quarter to a third lower than they are running because you're not using your legs. You're not using the muscles in your legs very much. You're just using the muscles in your upper body. So there is less force being generated. Therefore, there's less energy being used. So you're using less oxygen. Okay. Altitude and pollution can play a big role. If I have you breathe in polluted air, your VO2 max goes down. We interviewed a guy for a job a few years ago, and he wanted to put a diesel engine in his lab and basically pump the exhaust from the diesel engine into the air and have people exercise and breathe in that polluted air. Because if you're in large cities where there's a lot of pollution, it can affect your VO2 max. And if it affects your VO2 max, then it's going to affect mortality rate. So that can be a big deal when you go to altitude. You go up on a mountain, there's less air, and so your VO2 max goes down. That's why doing any kind of exercise at altitude feels worse because it's a higher, your max has gone down. So it's a higher percentage of anything. And then as we said, if you have any kind of disease like cardiovascular disease or COPD or something. Okay. Don't worry about absolute versus relative VO2. It would take me probably a good half an hour to try to really explain what the differences between these two things are. It's a measure of the same thing. Relative is what you guys have seen already. Relative is its VO2 expressed relative to body weight. So it's this mLs per kg per minute. This is the measure that you're most often going to see. It allows us to compare among people because it's normalized to body weight. Okay, that's all that I really want you guys to know. So we've talked about how to measure it a little bit in response kind of there to Preston's question. When we do research with this, the best way to test it is to do what we call a maximal test. We collect the air that you're breathing. We do something called open circuit spirometry. We put you on a treadmill or a bike, or they have, you name it, they have an exercise apparatus for it. At the Olympic Training Center in Colorado Springs, they have what is basically a cross-country skiing treadmill. And so you cross-country ski. Has anybody ever been cross-country skiing? Cross-country skiing is maybe the single most taxing metabolic thing that you can do, because it requires so much upper and lower body, even more so than running. And so a lot of the highest VO2 max values that have ever been recorded have been recorded in men and women that are cross-country skiers. But we could measure it on an elliptical if we wanted to, or on a bike, or an arm crank, or you pick the device. Okay, so that would be a max test. Anything not done on a treadmill is not called a max. It's actually called a peak test, which is just a semantical thing that lots of exercise physiology scientists like to get really bent out of shape about, whether you call it a max test or a peak test. Dr. Mike, I assume, will talk much more about kind of the hows and whys of that in exercise phys. We're not really going to spend any time on it, okay? But what you guys are going to do for lab this time, and what we would normally do in lab, is some sort of what we call a submaximal test. And what we do is we're going to estimate what your VO2 max is based upon your heart rate, or your heart rate response at some submaximal work rate, okay? We will get into in the next few slides how we use heart rate and how heart rate tracks with oxygen consumption. But the idea behind this is that we have you run a certain distance at a particular pace, okay? You're gonna run a mile at 9-minute per mile pace, and we measure what your heart rate is at the end of that. And based upon what your heart rate is, we can, at that particular pace, we can plug that into some equations and estimate out what we think your VO2 max is this. People that have a higher heart rate while running a mile at a 9-minute per mile pace are likely going to have lower VO2 max values. They're going to be less fit than somebody that has a lower heart rate at a 9-minute per mile pace, okay? The test that we normally do in our lab is something called the YMCA test on a bike, and you ride the bike at these increasing work rates. So it's just like a spin bike, and we crank up the resistance, and you do 3 or 4 different resistance levels, and we write down and we measure your heart rate in response to these increasing work rates. So we get these heart rate data points, and we draw a line through them, and we estimate out then what we think your maximal, at your maximal heart rate, what would your maximal work rate be, and we can use that to estimate your VO2 max, okay? Submaximal testing is better than no testing whatsoever, okay? It's better than no testing. However, all of our submaximal tests are only going to be estimations, and so they are all in some way, shape, or form going to be a little bit flawed as a test, okay? Because they tend to rely on heart rate, anything that can affect your heart rate, okay? Stress, caffeine consumption, cocaine consumption, okay? You name it, whether it's hot or not when you're doing the test. Anything that can affect heart rate, which is a huge number of things, can adversely affect our results. And so for whatever reason, when you're doing the submaximal test, if your heart rate is abnormally high because you had a cup of coffee beforehand, then it's going to underestimate what your true fitness levels are. If I gave you, say, a beta blocker, something that blocks the effects or blunts the effects of the sympathetic nervous system on heart rate, so it keeps your heart rate lower, then your heart rate's going to be abnormally low at a given work rate or a given running speed, and it's going to overestimate how fit you really might be there, okay? So there's just some limitations to our test, and we just want to acknowledge what those limitations are, Okay, it doesn't mean that the tests aren't good and the tests aren't useful and we can't learn some valuable information from them. We just have to take all of our results with a little grain of salt and just understand that if I do a submaximal test and it tells me that Whitney's VO2 max is 50 mLs per kg per minute, that it may be off a little bit. Okay, it may be off 10 or 15% one way or the other. Okay, that's all. All right. Okay. It is 11:41. Let's take a break. Let's take a break until 11:47. Okay, and then we will come back recording again. All right. So the idea behind all of our submaximal tests, okay, and this is what you guys are going to put to work in lab, somewhat, okay. Although I know not all of you, we're not really going to use, if you've got heart rate, if you have an Apple Watch or a Fitbit watch that will give you heart rate while you're doing your thing in lab, then I will ask you to record it. But if you don't have one, then we'll be okay. But the idea behind submaximal test is that as exercise intensity increases, okay, so as work rate during exercise goes up, as VO2 max goes up, heart rate is going to go up in a very linear manner in conjunction with oxygen consumption. So what this means is the heart rate is really our marker of the increase in cardiac output. It's the increase in oxygen delivery, the delivery side of things to the working muscles, okay? Of all of our measures that we get, heart rate seems to be the thing that most closely correlates with oxygen consumption that we can measure in a cheap and relatively reliable manner, okay? Especially with the advent of heart rate monitors and watches and things now that are much more readily available, we can measure heart rate during exercise, okay? So we could measure cardiac output. That would be even better, but to measure cardiac output directly, I would have to run a central line. So I'd have to run a catheter into your aorta and your superior vena cava and measure what's going on there. Measure measure stuff that's directly leaving the heart. Which, if we lived in a Scandinavian country, they wouldn't care about us doing that very much. But the OU, IRB, and the med school tend to frown upon us wanting to run arterial venous, like central line catheters, probably with good reason. So heart rate is the thing that we measure. To do an estimation, we're going to base most of that estimation on this close relationship between changes in heart rate and changes in oxygen consumption. Okay. All right. So I've got some things here. They're going to talk about kind of differences between maximal and submaximal test. I have some stuff on what we do when we do the YMCA bike test. Since we're not doing the YMCA bike test as part of our lab, we can, for the most part, just ignore all of this. And so we're gonna kind of work our way through that. What we are going to do in lab this time is there are several what we call field tests. Okay, so we can have you do a 1 mile walk. All right, we can measure how long it takes you to walk a mile, and we can measure your heart rate at the end of that walk, and we can plug that into some equations along with your age and your weight and your sex, and that can give us an estimate of your VO2 max. Okay. We can, if we wanted to, we could also have you run a 1.5 miles or run for 12 minutes and see how much distance you cover. So we can do these jog and run tests. And theoretically, if it's a set amount of distance, the faster you cover that distance, the higher your VO2 max. If it's a set amount of time that you're going to go, the more distance you cover in that time, the higher your VO2 max. So what I'm going to look at having us do for a lab is doing something that's related to these two things, but it's called the 6-minute walk test. And so you guys are going to see how much ground you can cover in 6 minutes. And then for those of you that have heart rate available to you via like a Apple Watch or a Fitbit or some other kind of device that you already own, then I may have you guys extend your 6-minute walk and actually try to walk for a whole mile and record the time and record your heart rate. And so we may have some additional kind of 2 estimates, and those of you that could get us 2 that we might be able to compare. Okay, but I'll give you guys more details about kind of how and the why of all of that probably come Monday when we assign it. I need the weekend to test it all out for myself. All right, so that's how we would do these submaximal tests. There's a slide on kind of field versus lab tests on advantages and disadvantages. It's mostly about the accuracy of the test and weighting that against, do you need expensive equipment, and kind of the practicality of everything. Okay. So the last couple of things that I want to get into very, very quickly, and we won't have time to finish all of this, but we can do a little bit more tomorrow, is what are the training adaptations? And then we need to get into how do we train, okay? So if we know, okay, that cardiorespiratory fitness, or that VO2 max, is going to go up when you do endurance type training. So when you go run or you go walk at a very fast rate or up a hill or something like that, you can train and make your VO2 max get higher. The average person can see somewhere between maybe a 10 to about 40% increase in VO2 max if they train consistently for maybe 8 to 12 weeks. Okay, 8 to 12 weeks. It may take, for us to be able to make a laboratory measure of an increase in VO2 max, we may see it as quickly as a week, but oftentimes it takes 2 or 3 weeks for us to see these kind of noticeable changes, okay? But most of you should be able to improve your VO2 max to a pretty reasonable extent, okay? So that begs the question as to why. What's changing in the underlying physiological systems that will allow you to deliver and use more oxygen in your muscles without, to be able to make more energy and do a higher work rate? Well, one of the big things that happens is when you train aerobically, the number of mitochondria in your skeletal muscle will go up tremendously, okay? You can see as large an increase as a double, okay? So if you have one muscle fiber and it has 4 mitochondria in it right now, if you do aerobic training correctly, then you may now have 8 mitochondria, okay? So it's very difficult. We don't see things on that order of magnitude in a lot of our other systems. So you have this really big ability to increase mitochondria. So if you have more mitochondria, like if I could just inject Hannah with mitochondria, okay, this would be a great way to do some cheating on an endurance test. Is I inject Hannah with mitochondria into her muscles, and now for whatever her cardiac output is, she can now extract and utilize more oxygen. We've changed nothing but the mitochondria, and her VO2 max will go up. Okay. Your lactate threshold goes up, so the work rate at which you begin to make lactic acid, which will cause fatigue, that work rate's going to go up. I don't really want to get into a whole lot of the hows and whys of that, of the things that we talked about the last 2 days. So you have the skeletal muscle side, you get more mitochondria, and then in the cardiovascular system, we see a couple of big changes. One of those is that your total blood volume will increase, maybe 20 to 30%, okay? So if you have 4 liters of blood right now, after 8 or 12 weeks of aerobic training, you may now have 4.5 or 5 liters of blood, okay? So there's more blood. When there's more blood, there are more red blood cells. More red blood cells, even if your hematocrit percentage hasn't changed. You went from 4 liters of blood at 40% red blood cells to 5 liters of blood at 40% red blood cells. That's still more red blood cells. So you can store more oxygen in your blood, which means there's more oxygen available now for those increased mitochondria to be able to suck out of the blood and use to make energy. Okay, so blood volume goes up. we can see increases in blood volume in as little as like 2 days, okay, in as little as 2 days. And that's mostly driven by changes in urine production. The initial increase in blood volume is almost totally from an increase in blood plasma. The additional red cells kind of trail the increase in plasma. When you exercise, you get hot, you sweat, you release aldosterone, an antidiuretic hormone, and it makes you retain a little bit more water at the kidneys. So your urine output may go down a little bit, and your blood plasma is going to increase, so your blood volume goes up. We're also going to see an increase in stroke volume. Okay, so an increase in stroke volume means that my cardiac output can go up. So the increase in stroke volume may be 10 to 20 to maybe 25% in most people. That increase in stroke volume is mostly going to be driven by an increase in the size of your left ventricle. Okay, when you train aerobically, you get an enlargement of the left ventricle. Okay, so your heart literally gets bigger. Okay, your heart literally gets bigger. And so that means that every time that the heart beats, it can eject a larger amount of blood. So that helps for if you need a certain amount of cardiac output to run at 8 miles an hour, then as you become more fit, as you get some cardiac hypertrophy, your heart rate at that running pace is going to decrease because your stroke volume has gone up. So if your stroke volume goes up, you can reach the same cardiac output as before out of a lower amount of heart rate. So one of the key ways, really, if we want to estimate who's the most fit, is to measure your resting heart rate. People that are very, very high VO2max values have very big stroke volumes. So they have very low resting heart rates, like down into the high 20s or into the 30s. Okay, and that's kind of what's going to happen. Training does not alter age predicted max heart rate, not one bit. Okay, not one bit. You cannot, until you get to be maybe like my dad's age in his early 70s, you can't really have a lot of effects on being very fit on age predicted max heart rate. Okay, as you age, the SA node just naturally becomes less sensitive to epinephrine and norepinephrine, and that's going to lead to some level of a decrease in your age predicted max heart rate. So when you train, cardiac output goes up, and that's almost solely from these increases in stroke volume. Okay, so you're going to get increases both on the delivery side because cardiac output goes up, and on the utilization side because you're going to have more mitochondria in your muscles. And there are certainly some other adaptations and things that take place, but the physiology to understand them is a little bit beyond the scope of what we normally will cover in this particular class. Okay. All right. So let me look at how we're doing on time. I'm going to take 3 minutes and just really, really quickly hit something here, and then we'll finish up the rest of it tomorrow because I want us to do this other exercise, okay? So when we want to prescribe endurance or aerobic training for people, okay, we need to consider several things. Much like with resistance training, we needed to consider, right, frequency, intensity, time, and type. We've got to do basically the same thing with endurance training. And what we've got to be very careful about then is how long should I do the exercise? How would I figure out what the intensity is so that I can make sure that I'm getting a sufficient amount of overload? So the same principles that we used for doing and looking at and evaluating resistance exercise, we need to do when we look at the at aerobic exercise as well. Okay, and so we typically look at 4 things, right? What's our training intensity? What's our training duration? What is our training frequency in days per week? And then what's our mode of exercise, right? So am I running, or am I walking, or am I biking? That's the exercise mode. So the combination of all of these things is going to give us something called training volume. In order to increase your VO2 max, you need to increase your training volume, okay, based upon what you are normally accustomed to doing. And so you can alter that by increasing the frequency of your training. So you can do 4 days a week instead of 2. You could increase the duration of a particular bout. Maybe I'm still doing 2 days per week, but I'm doing 45 minutes instead of 30 minutes. Or you can increase the intensity, okay? And in this instance, intensity means at what percentage of your maximal VO2 are you working during a particular training session, okay? If we know that you have some max VO2, that's going to be our analogous variable to, say, maximal strength or the 1 rep max. And so there's a zone of intensities that you need to be at a certain intensity, a certain percentage of VO2 max during exercise, or you're likely not going to tax the cardiorespiratory or tax the mitochondria enough to get them to adapt, okay? And so we'll talk about the ins and outs and like how many days do we need, how long do they need to be, what is that band of training intensities that's going to give us the best chance. We'll talk about that first thing tomorrow. Okay? All right. So what I'm going to do is I'm going to stop on the share.